So it's entitled New Options for Treatment of Hormone Receptor Positive Breast Cancer. One of the things that really strives me and the foundation in terms of our interest for education and empowerment of people that face cancer is to remind folks that at least as it applies to cancer, breast cancer is definitely one of the most common forms of breast cancer. And you see, I don't really have a laser pointer, or if I do, I don't know where it is, but you can just see just from the slide, it affects many countries. It is a worldwide problem. It is one of the most common cancers in the United States that affects women. And by year's end, based upon recent American Cancer Society statistics as of 2015, it is estimated each year now we see over 230,000 new cases in the United States alone. This is why we really care about this disease in terms of how we can make things better. But that obviously is a serious statistic in terms of how common this disease is. And many of you are here tonight because you've been either affected or you take care of folks who have this disease. But it does seem like even if you haven't been affected, you know there's someone in the family that's been affected with this disease. It is a common disease. Why we're talking about hormone receptor positive disease tonight is because 70%, at least 2/3 of individuals diagnosed with breast cancer will have what we call hormone dependent breast cancer, known as estrogen receptor or progesterone receptor positive state. And we'll go over a little bit about what that means in the slides that I'm going to provide. And then 20 to 30% of individuals with early stage breast cancer. So individuals, I just got diagnosed, I had my mammogram or I found something, I got diagnosed with breast cancer. When you do additional tests, you find that 20 to 30% of them will have recurrence, after their initial treatment will have a recurrence of breast cancer. 4 to 9%, under 10%, but still a good number, will present with stage 4 or metastatic disease. And still, I've been doing lectures about breast cancer for almost 20 years now. The statistic of 40,000 individuals dying each year from breast cancer is really overwhelming. So that's why research still must be done. Now again, this is back to what I was saying earlier. I don't know how well this projects, but what I want you to take and glean from this trial, this slide, is just the idea that breast cancer is not one disease. Actually, I even had a patient today remind me that even within one type of breast cancer, you might have a mixed population of different types. But this is a slide that was, that we all kind of look at, talking about that breast cancer really now has been subcategorized based upon analysis that we do initially of whether or not the estrogen receptor is or is not present, and if there is another receptor called HER2. And then just simply based upon whether someone has estrogen receptor positive disease or not, there is a difference in prognosis. So you don't get to choose what type of breast cancer you have, but the point of it is, if you get breast cancer, right? I've already told you that it's a common form, but if you do get it, if it's hormone receptor positive, as you can see from those slides, and these two are representing subtypes of different estrogen receptor or progesterone receptor positive breast cancer, even though the curves don't look good because they all seem to drop, you can see that at the top, the outcomes in terms of survival is best, at least from that analysis, particularly before we were using treatments for HER2 new disease. That prognosis is best when you see individuals with hormone receptor positive. So even though there's some things you're going to learn about the disease, most individuals are expected to do well when they have this type of breast cancer, but there are more than one type. So that was my sort of introduction to this in terms of how I'm going to try to tackle this. I thought it'd be nice to share some history. I'm now getting older, and I realized I thought I was still okay, but when I'm thinking about 1900s, that some people haven't been born in terms of 1900s, but it's always good to look at your history. So I'm going to go a little bit back into like 1800 and early 1900 experience to give you sort of a glimpse of how we learned some things about this disease, even before we learn the things that we now take for granted today. I am going to talk about pathophysiology, what this type of structure of breast cancer and how it influences tumor growth. I'm going to go over that with you. And then I'm going to be talking about previous and current things that we do to approach breast cancer like this. But there is going to be a fundamental essence that I want to share with you about, and in this disease, even though it's usually favorable and people tend to do well, that there are some categories or some individuals who go on to have recurrence because of innate or acquired resistance. Antibiotics for UTI, 3 times I've done, the 4th time that antibiotic doesn't work, that there's an acquired, and sometimes even at the beginning, a tendency not to respond to the block of the effects on estrogen receptor. So resistance. And then some of the newer strategies, I had to talk to one of my patients who couldn't come tonight about some of these new ideas. And then this is where I'm going to be very concerned about the time, but new agents, new drugs, new approaches that we're doing that are maybe more successful now that we're learning more about this disease. And then there's a drug that we use for osteoporosis that I wanted to share with you about that has a role potentially in women who have hormone receptor positive disease, if you're still here by that time. And then I'll probably go through that real quickly about some of the novel agents that clinics like ours, START, and the University of Texas here in San Antonio are studying to do better approaches, novel approaches for breast cancer. So, right? We got it, right? No problem. Okay, so history of treatment of hormone-sensitive breast cancer. One of the fundamental approaches that oncologists use when a woman comes in with breast cancer that we just determine by testing is hormone receptor positive is this idea of reducing the concentration of circulating estrogen. This gets back to some of the things you all hear about hormones being dangerous for breast cancer, which just like certain exposures, that's not always true. But when someone is diagnosed, one of the fundamental strategies that have gone in from the beginning of time to today is trying to reduce the circulation of estrogen, either through the signaling, and I'll talk to you a little bit about that signaling, reducing the estrogen production, creating sort of a menopause state. That remains and has fundamentally always been there as a key component to treatment. Back in the 1800s, and it's always nice to go over the history, George Thomas Beatson, he's most recognized. Actually, there were a lot of other folks that really began to discover these and made observations about the role of maybe hormones. They just didn't know what it was some substance in their mind. But he is the most well recognized and cited for this, what we call castration, removal of hormones in women who had breast cancer. So back in 1896, no, I wasn't born in 1896, but not too far away from that. But early reports and the Lancet publication back then reported his experience. One of the things I think he did was he captured, he observed, and documented, and he was able to report in a reputable journal his experience. And he observed by removing ovaries in women completely. This is from looking at animal studies and seeing if animals were castrated, that there was a reduction of breast masses in animals. So he thought maybe if I remove the ovaries from a person with breast cancer, maybe they would do well. And so in 3 women with what we know had to be very advanced forms of breast cancer, they had improvement in their disease control by doing that. Now, he didn't know what estrogen was when he did it, but he figured there's something in there that had to do with those ovaries. Again, another scientist, really amazing things that they were doing with very little understanding. Thomas William Nunn, he actually also noticed that in patients with breast cancer that there was a regression of the breast cancer that you could see, because remember those days we didn't have mammograms and things like that. You could just see the breast cancer when they actually went into menopause, when menstruation stopped. So, there's something there that is unique in women. Other specialists, including a Dr. Stanley Boyd, performed again bilateral oophorectomy in many patients who had advanced breast cancer in the 1880s, guys, and 1890s, and published a report in 1900. And what was interesting, when they did this procedure, they noticed an observation of 1/3 of patients had a clinical benefit. And many of the drugs that we are talking about for current therapies with recurrent disease, sometimes we quote a 30 to 50% improvement in the disease in 2016, and they were seeing this in 1800s. Humbling. The process of estrogen as a hormone was actually not first discovered. Now that may seem really long time for you all, but not too long for me. 1923 was actually when they first discovered estrogen, and this was by a scientist, Edgar Allen at the University of Missouri. And then one of the confounding things scientifically that the more you do, you kind of have more questions that are generated. But this is a phenomenal observation. It's Alexander Hadow in the 1940s. He actually looked at the structure of estrogen, and he discovered that if he used what we call strong, high-dose concentrations. And when I came in fellowship, and again, this is why I realized how old I'm getting, they were still using things like DES, but they use high doses of estrogen. And we always say, no estrogen, right? Get the estrogen away. But high doses, in individuals who were postmenopausal, they had a 30% improvement in their disease burden by taking high-dose estrogens. So that's kind of counterintuitive. Maybe you're just overwhelming the ligand, the recipient, that receptor with a high concentration, and it actually shuts down the system to stop the breast cancer production. And until the 1970s, DES, which also was used in prostate cancer, which is a hormonally driven disease, was actually used quite successfully. When I came on board around the 1980s and started to do my fellowship, we actually got away from it because the high estrogens were associated with high cardiac events. So high dose estrogens were a danger, but tamoxifen also became, again, structurally very similar to the early estrogen experience. And we still use tamoxifen today, but in the 1970s is when it started to be used. And so that seemed to be safer and probably, honestly, a little bit more effective. But historically, that's really interesting that about 30% reduction was some, what we would think is kind of odd or archaic type of treatments to be very successful. And the doorway, the receptor, was not actually first discovered until 1958. So what the heck are they? I remember many years I was trying to talk about estrogen receptors, and I had these little booklets that I think you guys have at your seat. And one of my patients' husbands said, the doorway. It's a doorway. And I'm like, God, that's so good. You know, it's the entry area for the cells. So estrogen receptors, can you all see this still in the back? Are we still good in the back? Well, I guess you can hear me now, but are you guys seeing okay? Okay. Yeah? Yeah? Okay. They're referred to as a group of proteins found inside and on cells. They function as what we call transcription. You remember transcription? Transcription factors when bound to the ligand being this hormone called estrogen. And in most of our discussions, we're thinking about an actual entity called 17-beta estradiol. There are two forms of estrogen receptors. I promise there will be no tests, but there are points to this. That's why I'm putting this in here. So you have to understand that as I'm starting to get into this now, it's going to get a little bit more bogged down in terms of information. And just get the gist of what I'm saying when I start to go into this, because these bits of information influence the kind of strategies that you'll see that we're using right now. So the two estrogen receptor subtypes, they're called isoforms, are estrogen receptor alpha, estrogen receptor beta. And actually, they have genes that actually specifically are responsible for encoding them. The hormone ligand activated receptors form dimers. It's like if I bind to you and I'm an alpha and you're a beta. We bind together, and that's a dimerization. So that's the binding that occurs. It's very key in terms of the signal that occurs downstream towards the DNA. So there can be homodimerization, where you have two estrogen receptor alphas or two estrogen receptor betas, or you can have an estrogen receptor alpha, as I just said, and beta. And that kind of matters too in terms of some of the things interaction-wise that occur. Little crazy, you don't have to worry about that, but just to know that there is that complexity. The other thing that I want you all to just get a gist is that we have all these kind of mechanisms, but we also have things that actually activate the signal from when the binding occurs at that doorway, and there's things that repress. And depending upon whether there's co-activators or what we call co-repressors, that may diminish the signal to get down to the DNA to make more cell production, or it may diminish it or activate it. So it's very important to know that that's another thing that has been found scientifically that actually does influence whether that message gets down. So far, does this make some sense? Some people say, I don't know, but we're good so far? Okay. And then there's a ratio of the alpha and beta that can matter. And then, of course, when we talk about alterations, there's all these different types of genes that also influence messages for either turning on or turning off messages as far as tumor growth. Remember, we're talking about tumor growth going through that door. We walked all through that doorway into this room, and it's what happens once we get inside in terms of what's going on there. That really influences how much cancer or cell growth will continue. That's the point. Now, I've got some pictures, so just stay with me in terms of the description. There are 5 segments. Whenever I think about the receptors in cells, I think about, and I always say this in my talk, Horton hears a who. Does anyone know? I got to kind of get you. Horton Hears a Who, Dr. Seuss. My kids will laugh about this because I actually watched it, yes. Does anyone know that story? The elephant, he could hear that there was some sound helping, please, please help. Is anyone with me? We all know that. And that, right? Thank you. Thank you so much. I knew there'd be someone who would bond with me here. And then, you know, they called him crazy, it was silly, blah, blah, blah. And then it was really what happened. There really was a whole town and this little speck of dust that he was protecting, remember? So when you start to hear this complexity, there's a lot going on in this receptor. That's the take-home message as far as what I want you to know. But there's 5 segments labeled A through F, different types of distribution, and there's different regions that have different responsibilities. And the first segment, this leads to gene transcription. You don't even have to have binding of the estrogen to that to make cell production occur, but it's probably a weak signal as far as the growth. There's a C region, that's where the DNA actually binds, and you'll see a picture here shown, and then there's a hinge, and then there's this E domain. I mean, it's very complex. Horton Hears a Who. Lots of things going on in that little doorway. And this is actually more of a picture in terms of how we think about the receptor conceptually. And you see this is an alpha, which is a little bit longer, you see in structure, than the beta. But those are the kinds of components and I want you to take home with you the understanding of, dang, that's really a complex system in terms of how that interaction occurs. That's really the message. I mean, it's very phenomenal. I mean, I'm not the best scientist in terms of going over all this. We've got a wonderful scientist in our crowd tonight who I know could explain this a lot better than I am, but it's just really to give you an understanding of how complex in these DNA binding areas, and see the ligand binding, which is where the estrogen binds. You can see again how complex all of that is in terms of what really is happening at the entry. And when we say the entry, it's more of like an upstream, and then as things go down from that point towards the DNA division, that's more of a downstream. So it's really complex in terms of the information. Now, typically, the estrogen receptor is what we call located more in the cytoplasm of the cell when there's nothing that's really bound to it. But once the estrogen binds to it, again, I'm using you probably did sit in the wrong place, but I bind to you with the estrogen. Once I bind it, there's movement then of that receptor inside. So that, again, this activates or allows for transcription and DNA division to occur. And this is where that dimerization also takes place internally. There are these areas called hormone response elements that are there. There's a lot of complex machinery that goes on in terms of once there's entry downstream. And then there's a lot of complexing with enzyme systems that really empower energy to the signal so that once we have energy, we can go ahead and carry on the signal. So those are tyrosine kinases and things like that. So this is more of a pictorial. And again, this is where if you're in the back, you may not understand or see things very well. But I've got estrogen. You guys gone to sleep yet? Estrogen outside migrates in. We have then binding to the receptor. Notice now its location near to the DNA. And then once it sits close to there, what do we get? New cell production. Now this is a normal system that normally occurs when the breast is not malignant. This is what I'm showing you. This just keeps going on when it becomes malignant, and it still has that doorway there. But this is set up for normalcy. This is what happens in a normal situation. So this is where we talk about new cell production based upon that binding, okay? We're good? I don't know if anyone ever thought it was that complex. I know it's really been a struggle for me to understand. And this is another way to think about it. Estrogen outside of the cell moves in, binds to the receptor, goes towards more towards the downstream area where you have gene transcription. You get new cell growth, metabolism, and new blood vessel formation. You got to have blood vessels. Why? Just like food and stuff, to nutrients. So all of this is turned on when you have that interaction, just from that migration in. So that's basically how cell production starts. Estrogen is a key driver. That's where we've been really struggling when you've heard times where people have been told maybe we should not take hormones so long, or maybe there's a danger to hormones because after a while that may promote cancer cell production. So there is, I'm not saying to everyone that you can't do hormones, though we do have a lot of this conversation about that, but that's where that kind of, it starts in terms of the estrogen binding. Now, knowing that this has happened and what goes on, it's natural that if you know what's going on in machinery and it's now a malignant cell, what can we do to fool or confuse the system so that we send a different message so that we stop production? So as I mentioned early on in terms of the history, tamoxifen was actually, I don't know if anybody knows about that drug, but tamoxifen was actually created to be a birth control medicine back in the 1960s in England. So it's not by mistake. I don't know how good it is for that, for birth control, by the way, but it was obviously seen in animal studies to antagonize cancer cell growth, and so that led to its acceptance once we started to see its tolerance to be used as a potential agent to replace some of these high-dose estrogen for breast cancer. Again, once you know what is going on in terms of stimulation of the cell, you do something that looks like the estrogen to the receptor, but when it binds to that receptor, now it's going to send a different message. Cell growth stops. Does that make sense? So it's actually referred to as a SERM, or a selective estrogen receptor modulator, because tamoxifen, when it binds to receptors that are called hormone receptors and the uterine lining, it actually makes it thicker. Or if it's in blood vessels, it makes those more prone to clotting. So we've had some situations where women have worried about uterine cancer or uterine thickening with tamoxifen or clotting. But in breast cancer, it works as an antagonist. So selectively in different organ systems, it works differently. It sends a different message. And so it binds to the estrogen receptor and results in sort of this nuclear complex that reduces DNA formation. It stops the cell production. It alters the estrogen receptor configuration, and it prevents things by binding to coactivators and prevents transcription. So if we stop the transcription, we stop the signal, then we can actually stop growth of cancer. It does, if anyone's ever been on tamoxifen, can tell you that they feel like hot flashes and menopause, right? Because it does influence an antagonist effect to estrogen. Even though you still may be premenopausal and still producing estrogen, you can still feel like you have you're in menopause. And it actually, because of some issues about testosterone and its conversion to estrogen-like substances, tamoxifen is actually more preferred than what we call aromatase inhibitors in males who have breast cancer. And by the way, I told you that 70% of cases were estrogen receptor positive. If you look at male breast cancer, which is only about 1%, 90% of men who have breast cancer have hormone receptor positive breast cancer. So it is one of the mainstays of treatment, particularly for early stages of breast cancer in men, to use. And it does sort of stop or slow down the process of tumor growth and arresting cell division in early phases of mitosis. Now this is the slide that I think is really challenging if you're way in the back, because it is a sort of a summation of the different things that we use currently for treatment. We actually have medicines that we use for the brain. I'm going to talk a little bit about that later on when I talk about ovarian function suppression, that we actually can work, that are given that work in a way that we call agonistic for hormones that actually are stimulatory for the ovary to tell the ovary to produce more estrogen. We can give medicines that can fool that receptor and make that message stop. So that's one area. There are drugs called Lupron and Zoladex that we use in premenopausal women. We actually have a drug called Faslodex, which actually degrades, gets rid of the estrogen receptor. If you don't have an estrogen receptor to bind to, then you can't have a signal, right? So that's another drug that we use, and you'll hear a little bit more about that in the talk. Am I boring you guys so far, or is this making, it's okay? We also, in women who are in menopause, I have women who are in their 80s that I give estrogen blocker therapy to. At a time in our lives where we produce, in our minds, the least amount of estrogen, that is where the most common occurrence of hormone receptor positive breast cancer occurs. And it's kind of an interesting thing that I still haven't really thought through, and that's why we have scientists and folks who can think about it. prostate cancer is also a disease that occurs in men as they age and where their testosterone level gets low. And the sensitivity at that time to any hormones that we produce, men testosterone, estrogen, and women with breast cancer, stimulates cancer growth, where we really aren't making a whole lot of it. So I have some women come in and said, I don't know why you worry about estrogen, honey. I don't make any estrogen. I haven't done that for a long time. But we actually have a mechanism through the adrenal gland that produces androgens all the time. And then there's an enzyme system that actually lies in fat cells called aromatase. And when the aromatase binds up with the androgen, it converts androgens, which don't seem to be stimulatory for breast cancer, to estrogen that does stimulate breast cancer. So one of the main strategies that we use in women as they age is a drug, a pill, that's called an aromatase inhibitor. And it interferes with that enzyme called aromatase, and if there's nothing converting that androgen to estrogen, you don't make estrogen. So you would deplete even further the estrogen production. So that's one of the main strategies that we utilize in older women with breast cancer. So these are just some current, pictorially, strategies that we use now that we understand how the estrogen receptor matters in breast cancer growth. Does that make sense? Still reducing that estrogen substance, as I told you early on. Okay, so that's current, and this is current too, but it really caught a lot of attention because for many years, this is not really new in this idea. I talked to you about how we have medicines that can actually stop messages that stimulate the ovary to produce estrogen. What if you just suppress the ovarian function? A lot of women, once they get diagnosed with breast cancer, they're still premenopausal, will say, what about just removing my ovaries? You know, like they did back in the surgical days, but I showed you that benefit of removing both ovaries. But what if we want to do a medical way of just suppressing? And what is the role of that? And is there anything really novel in terms of improvement over some of the strategies we've used to date? And about a couple years ago, there was a lot of reports, and I'm going to go over some of the slides with you about some of the studies that were done, looking at ovarian function suppression, suppressing that message to the ovary to produce estrogen, and then using it with tamoxifen, sort of a synergistic, using two drugs or two strategies together to block that estrogen signal, or use, once you've created someone to have a temporary menopausal state, because the medicines put them now into menopause, maybe now using an aromatase inhibitor like we would in a person who's already in menopause. And is there an advantage in adding this treatment? Does that make sense? So there were two trials, and I'm sorry this is not very large. The whole idea is that tamoxifen and exemestane is an aromatase inhibitor. It's one of the kind of those drugs that I talked to you earlier a few minutes ago about blocking that enzyme system so that we don't produce as much, have much conversion from androgens to estrogen, and using tamoxifen and shutting down, putting the person into temporary menopause. So that tamoxifen and exemestane trial was known as the TEXT trial. We use a lot of acronyms for our studies. And then there was another trial that involved a lot of women, 3,000, suppression of ovarian function trial that's known as the SOFT trial. And this was, again, only women, of course, who were premenopausal, who were producing estrogen, and they were using a strategy of looking at tamoxifen alone, which at that time was a 5-year plan, or ovarian function suppression with tamoxifen for 5 years, or the same strategy, but now using an aromatase inhibitor for 5 years. And what they wound up doing, since the trial designs were so similar and it was more potent, they combined both analyses. And so we had together a big group of people to look at in terms of whether those strategies were useful. Because the more numbers, then we can really make sure that the impression that we're getting is not a mistake, that this is really a value. And one of our big meetings that oncologists really go by in terms of new paradigm shifts and changes in our approaches is a meeting called ASCO. It's actually coming up in a few weeks. And in 2014, so just within the last couple years, they looked at individuals who had had follow-up at least for 5 to 7 years. And what they noticed with just addition of the aromatase inhibitor, you've created a menopausal state. And remember I say temporarily, because if I stop the drug, that shuts down the ovary, the brain to stop the stimulation on the ovary, if I stop that, the person can start producing estrogen again. So this is just a temporary effect. But if you create that temporarily and you add exemestane, there was an improvement significantly compared to those women who had tamoxifen and the same measure of treatment done. So in other words, getting someone into menopause in this way and then adding an aromatase inhibitor was superior than adding tamoxifen to that. When they tried to figure out who really benefited the most, it was women who were less than 40, who had, unfortunately, at the time of presentation, the cancer had already spread to the lymph gland, so they're a little bit more at risk for recurrence and dying from breast cancer. And so those individuals who were deemed higher risk seemed to get the best bang for the buck by adding this state. But here's the rub. For those of us who are gone into menopause and who understand what that is, there was toxicity. So I'm sorry, it's not that menopause is a bad state, but there are a lot of things that can happen as a result of creating this. So these young women were facing what women who usually go into natural menopause at 50s and 60s were dealing with, 50% depression. That's a significant toxicity. Menopause symptoms, hot flashes, sweats, osteoporosis, and sexual dysfunction. So what's interesting is this has been out almost 2 years. And it took me a long time to wrap my mind around the data and what this was really trying to tell me in terms of practice. Should I take my young women and do this with? But a lot of leading breast oncologists were really struggling with this because they had started to do this. Of course, best survival, want to maximize that because we want them to live. But their lives were absolutely miserable. So many individual oncologists said, let's present this data to our patients. But it was not necessarily a 100%, I'm going to go ahead and do this. Because the balance of this, living that way for many years with these kinds of side effects is quite significant. For that person who really has enough high risk, certainly I have a conversation with her, but it's not necessarily we're going to all do that just because. But the data certainly suggests that the more you, again, remember that first slide, estrogen reduce the estrogen even more, the better outcome in terms of survival rates. What about how long, and all of you all know this now, it's kind of like you guys are so well versed in all this. What about use of tamoxifen? When I started my oncology career, it was back in the 80s, and at that time we really didn't know how long to keep the estrogen blockade going. So I would have a few women, at the time it was just sort of arbitrarily decided at 5 years, and my patients would look at me and they said, you know, I'm doing okay with this, do you think maybe I should just stay on it longer? And we didn't really even understand about prevention at that point very well. That got decided and figured out in the early 90s. So some of my patients, we just stayed on it. And then it was around the mid-90s when some studies from the NSABP showed that women who continued tamoxifen after 5 years, that they may actually have more higher risk for breast cancer to occur after 5 years. And needless to say, particularly in America, you don't want to be that oncologist keeping your patient on something that might, right? I don't feel you guys at all. Okay. So there was a question of whether or not it was of value to take it. There might be some hazards. Well, what was interesting is, and this is why science is so amazing in terms of thoughtfulness and consideration, there was a large group of patients, I think it was like a 3,900 group of folks, but there was an ongoing study that was sort of developed around that same time, and known as Atlas and Adam. And they decided to actually, they understood that there was this concern that there might be a danger, but they just didn't know that it didn't make sense. Why would a drug that's been protecting you for 5 years suddenly become a danger after 5 years? What is the mechanism? So this study was done in the face of the sort of change in terms of paradigm shift to stop at 5 years and continued women on a formal consent process to extend their use of tamoxifen beyond 5 years or stopping at 5 years. And the general group was at least up to 10 years. What they saw was that there was, even in women who stayed on it between 5 and 9 years, that there was an improvement, but it was much more significant in terms of breast cancer mortality for those who continued at least 10 years. And both of these studies were concordant in terms of the fact that they showed that the longer you stay on tamoxifen, assuming that you're not having difficulty with taking it or there's dangers to take it, that the survival rates and recurrence of breast cancer was significantly improved. So now most of you all know that it's now recommended that when someone is diagnosed and they are going to be on tamoxifen, that you should stay on it for 10 years. So that's something that came from that very impressive study. In the face of where people said it's clearly wrong to continue, someone said, no, we will go ahead and continue this. And so this was the design of continuing to tamoxifen versus for 10 years or stopping at 5. And then there's a lot of slides that show that there's a difference in the group, that actually there was better outcomes in individuals who, there were less recurrences. This is the recurrence curve for those who stopped at 5 years, a higher risk of recurrence compared to those who continued the medication. So clearly a significant difference. And so that's why you're, not that we're mean oncologists to keep you on a medicine that might be causing you menopausal symptoms, but assuming that a person's tolerating it well, there clearly is now clear evidence that there may be value to extend its use, maybe even beyond 10 years. We even have data of the 10 to 14 years of use may be better. Now this slide is a slide from way back from one of the cooperative groups called ECOG, and it's to give you the message. And I always, when I'm giving these talks, as I see many of you who are my patients in this class, and think, God, I hope that they're not getting too freaked out by this data, that they're getting worried now about what I'm presenting. But one of the things that I told you earlier is that we tend to think about hormone receptor positive. I showed you that curve, that those individuals really, compared to other subtypes, really do well. But it wasn't early on realized that when you have gotten to the 5-year mark, that it might not be over. And so this is a curve that goes out to about 12 years, that in individuals who have breast cancer, that were on trials, that people just continue to have follow-up, you notice that recurrences, even after 5 years, keep happening. There are some, because of that, have said that this is a chronic disease, which I hate that term, but you know, that you never get rid of breast cancer, is always going to be there. And I actually had one patient in my practice who was a 40-year survivor. She was treated with a radical mastectomy in the 1960s, actually got chemotherapy, radiation, everything. And she actually, 40 years later, did get a recurrence of the original breast cancer. Never had any traces of it, but it was more of a subcutaneous, just like rash-like thing. It was more of a bother, it was. But it was sort of a very latent recurrence that just blew my mind, that something after 40 years would show up. So it does occur. This is rare. It's not 100%. So don't take home message that everyone will. But that because of that, this is what we're getting at in terms of trying to do new research ways of saying, how can we take someone who may have certain risk and maybe reduce their chances for a late recurrence, right? You guys are so quiet. I feel like I should come and start to massage you. So because of that, there's got to be something about the disease that, in spite of what you did, maybe made it resistant, that it would survive and just keep living, right? You're blocking down the message. Why the heck doesn't just die? You know, why? You know, and of course me, I'm very strong about that, but why doesn't it? So even at the initial diagnosis, some individuals have already some resistance. And if you can understand, like bladder infections as an example, in terms of something not working the first time and having to try something as a different antibiotic or whatever, you can understand the concept that even at, you know, remember these are cancers, so they can already have changes that make them not necessarily responsive. And then, thank you very much, Dr. Wilks, after you treat the patient, because of the treatment, I might create a beast, because I may induce with the treatments now a nastier or more resistant type of malignancy. Very worrisome in terms of what we're observing, but we're beginning to understand that this is a real issue in terms of those recurrences. So that can limit the effects of things like tamoxifen and aromatase inhibitors, which we have just shown, just shown you with some couple of recent strategies of how successful they can be. There's these point mutations, and I'm going to talk a little bit about this at the end of the talk if there's time, that actually have been realized that once I give an aromatase inhibitor to a patient, and if there is a resistant clone, I actually may have more of a challenging way to keep that person in remission, that there's now a new mutation that develops because I used an aromatase inhibitor. So that's just an example of some of the things that we're learning. And these go back to that alpha and beta. That's why I went over that exercise, because it does depend on sort of what's going on there in terms of interaction and influences the development of some of these mutations. So again, just want you to have the concept of that, but you don't have to worry about just the details. I mean, I find it very much of a struggle to get my mind around it fully. The reason that these resistance occur, we think, is because there's that variance in estrogen receptor alpha beta expression and dominance, co-activators versus co-repressors. If the receptor itself is modified, if there's an increase of the signal through a co-activation message, if the estrogen receptor doesn't need the estrogen to work. So I have women that I give estrogen blocker therapy to, and it's like I'm giving them water. It just doesn't seem to stop the cancer signal. It's not really depending on that estrogen anymore to grow. So that's another concern. There's different growth factor signals that sort of bypass the blockade of estrogen receptor that we now are targeting and looking at. And then trying to stabilize the estrogen receptor, the stabilization of the receptor, even if I'm blocking it. So I can block it, but it's still, in spite of that, still sending that message downstream to make more cells. And then, of course, there's always the issue of these drugs have side effects, and so some people just don't take the medication. Now, if you're like that, by the way, and you're not taking your medicine, and your doctor says, you're taking your medication, just be real and tell them that you're not taking the medication. Because there may be other options, there may be solutions to what you're struggling with, but not telling them, who at the end of the day does that hurt the most? The person who's not taking it. It just might as well just say, I'm not taking the medication, and then moving on. So this concept of estrogen independence is, I don't need the estrogen, but it's an estrogen. If I test the tumor, I take a biopsy, and darn it, it says it's still estrogen receptor positive, and I give estrogen blockade, so I should be stopping that signal, it's still going because it doesn't necessarily it's independent of needing that estrogen. Estrogen independence is what that means. Does that make sense? So that happens because there's crosstalk. And I can't really think of a way, but if I was here and I wanted something to the young lady that's way there in the back, and you were kind of blocking me here, and I sent a message to you to get the message over to her, you might be blocking me down, but the message is still going down to the DNA because you are helping me get that message on in spite of the fact that I'm blocked. So this is this crosstalk, and I have a slide or two that shows that, and there's these alternate pathways called PI3 kinase. Think of it like pyramidal or Broadway, and MAP kinase. So different signals and paths that occur in that Horton Hears a Who example where you have all those different things going inside of the cell. And this activation of signaling, it's really complex, right? You may have a little bit more appreciation of just how challenging this disease is. And maybe some of those oncologists are not so weird and dumb after all. But this is a really challenging thing. You can understand why sometimes when we use these therapies, why we still sometimes lose the battle. Because there's a lot of things working against us, even when we see a process that looks like it should be treated with what we have. And then again, this downstream, and the cyclin D1 is a real area of interest, and with one of the new drugs, it seems like that overexpression development occurs in individuals who've had aromatase inhibitors, again, or anti-estrogen therapy. Sort of like we make the disease more challenging because these new factors influence resistance. And then this is sort of my example of those streets. This is not by any way current, but you can see this PI3 kinase street. There's a MAP kinase street. And the example I talked to you about here, if I'm blocking this with tamoxifen, but I've still got other signals still telling the cell keep production, and I'm not blocking those down either, then the cancer growth continues. So we now understand that.
And you can't measure those.
That's right. We don't always know, but there are now molecular ways. The question was, you can't always know if this is really activated. But we actually do have ways to check for mutations through genomic profiling to understand if those things are present in a person's tumor. And if they are, then sometimes we can use, if drugs are approved, to block that down too. And so you see right here the aromatase inhibitors, but then perfect scenario where I can give an antibody against this, I can do an inhibitor of the tyrosine kinase energy system, I can give a medication there. This is a drug that I'll talk to you at the end, sort of towards the end of the talk, that's actually commercially available now, called Afinitor now. But we actually did some research, and a lot of folks in town have done research on this, that blocks this. And look at how close this is to the nucleus. So if I block here and I block here, then maybe I can stop the message so that new cell production. So this is what we're learning about how to maybe not just do one stoppage. We got to do some other signals that we'll just bypass because of that crosstalk kind of relationship. And I think you all seem to get the gist of what I'm talking about with that. I talked about earlier this drug called Faslodex or Fulvestrant. We've talked about the importance of the estrogen receptor again. and that if you can do something to get rid of that receptor, and that's a key area that you can degrade and get rid of, maybe again you can stop the signal. So you guys get the point of that. So Fulvestrant has been approved for women who have recurrent breast cancer. It is known as a selective estrogen receptor down regulator, and it works as an antagonist to, again, reduce that downstream signaling. There's many mechanisms of how it works. It blocks the localization of the estrogen receptor. It affects the energy-dependent shuttling system. There's a complex that forms with the drug and the estrogen receptor that makes that whole system in terms of signaling inactive. It's accelerated degradation of the estrogen receptor. It binds, blocks, and accelerates the degradation of the estrogen receptor protein. It's a pretty amazing drug, and actually a drug that many people tolerate very well. So that's been actually on the market for many, many years. But again, a new concept that came up a few years ago. And again, this is where it's always pretty cool if someone asks a question and probes. When you see some of the designs and you think about who would think to test that, it's really kind of cool. And this is one example where originally when Fulvestrant or Faslodex was first approved, it was approved at a 250 milligram dose. And it was compared to established treatments like the aromatase inhibitors and found to be pretty comparable in terms of its effectiveness. But I don't know, maybe it came from early phase 1 studies or whatever, but there was some folks who said maybe the dose isn't enough. Maybe if we increase the dose, and you know sometimes when you increase the dose, what happens? More side effects, right? So you get a little struggle in terms of whether there's going to be more value if you increase the dose. But this was a study called the first line study comparing endocrine treatments first, randomized phase 2, looking at individuals first against just aromatase inhibitors, and showed that Fulvestrant was good. But then when they looked at the dose, and I know these curves are kind of more subtle in terms of their difference, but actually as time has gone on, we have shown a significant difference if you double the dose. And actually, if you load the Fulvestrant, what we used to do is just give it monthly, but actually when you first start, if you give a dose 2 weeks apart, 500 milligrams 1 week, 2 weeks later you come back and do another, and these are injections, by the way, and then another one 2 weeks later, and then monthly, the levels get up quickly, much more quickly, and that dose is superior to a lower dose. And it's kind of interesting how people can come up with just doing that kind of study and make a difference significantly. When this dosing change was made, and people who had their first recurrence of breast cancer, survival rates were significantly improved by increasing just by another 250 milligrams. So again, when we say that science is not keeping up and doing a lot of things to make changes, that's really not true. There's some really amazing ongoing things, and that's what we want to share with you in terms of just hanging in there and believing in what we're doing and investing our dollars for research. Well, palbociclib, I couldn't have a talk about hormone receptor positive disease and not talk about this very new treatment that actually has been approved since 2015, February, and how it works in a different pathway to kind of influence and improve people who have recurrent breast cancer. So right now, palbociclib is only approved for individuals who've had the misfortune of having breast cancer come back. And then we tested it, and it's still hormone receptor positive. And now it's been approved for 2 different drugs to use in combination. And what was particularly interesting about it, and if time allows, I'll show you some other drugs that are being studied in research, it was we had never had a drug that worked in that area of the cell like this before. And that it was found to be a potent and selective inhibitor of that cyclin-dependent kinase. It's when you hear kinase, that's an energy enzyme, the enzyme that gives energy for signaling at the 4 and 6 levels. And these cyclin-dependent kinases are part of the cell cycle in terms of mitosis, and that regulatory process that either says stop production or keep production going. And so it's a key operator in terms of regulating whether tumor cells grow or not, if they're turned on or off. And disruption of this process, because they do have a key influence on tumor growth, was reported to be very common, this pathway, in women who had breast cancer, particularly those who had resistant or recurrent breast cancer. And so that led to the interest by scientists to look at that.
Question?
Yeah?
Yeah. How do you determine to use it for recurrent and not an aggressive strategy to circumvent?
You are such a perfect setup. So the question is, why don't we use something that looks good when they first get diagnosed? Okay, does anyone have an idea? What are the ideas? Why wouldn't you use your best shot up front?
Save it for the end, in case the other stuff is.
Save it for the end.
Not FDA approved?
Not FDA approved.
It's a new medication, you don't know all the side effects.
We don't know if it works in the early setting, and if we're already doing 95% in the early setting, is it really going to take us to a different level, particularly if there's side effects? So welcome to research. Oh my dear, I'll see something that looks amazing, and I want it for my patient when they first walk through the door, but I don't know if that is going to work the same way, have the same side effects, and if that person is going to live without the addition of that. So we don't have a real good strategy right now. Sometimes up front, we may start to define independent tumor types and say, this is a driver already, let me use this drug towards it, but you actually have to have clinical trials that verify that there is benefit. So that's a struggle for us, because sometimes these clinical research studies, if you use it in advanced or metastatic setting, it may take us 15, 20 years before we can say, yeah, let's start looking at it in more earlier stages. It's not that we don't want to, but we're just beginning. So that's...
So it was targeted specifically for recurrent or tested?
When you start to do research, you do it in your patients who the initial treatments didn't work. Obviously that didn't work, so we got to do something a different way. So that's the perfect population to say, if it can work in that kind of situation, which is obviously a very serious one because now it's reoccurred and it works there, then you can start to move it. So some of the drugs that we take for granted today, like Herceptin as an example, was used in individuals with metastatic breast cancer who had HER2 positive disease first. And it took a long time before people would buy into that, but when it did, and there was promise and improved survival, then we took it to the early phase, and so several years ago, that became the norm. So a lot of the things that you now are, you know, if you're coming into the experience, you are sort of the beneficiary of people who previously had to get involved with studies to prove that there was a benefit. Because intuitively we think this is going to be better, but sometimes it's not. But that was a great point. Why not use it if you know it works? And I'm going to skip over this, but just to let you all know that there's a mechanism in a different area in terms of regulation of cell promotion and cell division that this drug, palbociclib, particularly with the idea and observation of increased overexpression of this cyclin D1 in many cancer types that occur in about 35 to 40%. And that's another key issue. When a person is first diagnosed with breast cancer, they may not have this overexpression. So if I use palbociclib in them, it may not necessarily be necessary or beneficial because that's not a driver for the cancer. It's something that's more, though it can be sort of at real time, it's more of a acquired thing. So that's another point based upon the question you had. You guys have some major questions. I tell you, I have physicians in the room, they don't ask these kind of key questions, and this is really great in terms of concept. So this is pictorially sort of the DNA mitosis that you all probably remember and know about. And here's over to the side, the CDK4 and cyclin D system. See how intimately connected they are. And then when they're connected, these areas send an inhibition to an area called a retinoblastoma that actually, if it's turned off, if this is shut down by these two, then mitosis goes on. If I do something to block the signaling from these two areas with a drug like palbociclib, now this is no longer blocked and it tells the cell division system to stop. So here's yet another system that's influencing it from a negative versus positive feedback system. Isn't this amazing in terms of how science can find these things? But this is now the concept of how that drug works. And I think pictorially that makes a lot more sense than my slide would have in terms of just reading all that stuff to you, to just see how that mechanism works, right? And that is actually something that when taken to patients, because obviously initially was studied in animal studies, they began to show some promise. So early on it was used with the aromatase inhibitor letrozole, and basically they used the aromatase inhibitor, as we talked about, reduce the estrogen production, and then you add in palbociclib, and then this dual inhibition really seemed to make an sterling improvement in terms of estrogen signaling and reduction of estrogen as it was produced. And again, this particular novel area of attack was realized in terms of benefits. So after some studies were done in patients, and I have some schema of the design, last February 2015, palbociclib and letrozole was used in individuals who had the first experience with breast cancer. So I could say to a person, you've had a recurrence, This is usually something that you're going to do pretty well with, even if it's recurred, but now I've got something that will enhance and augment more tumor control and lead to a better survival rate. So it was initially approved only on individuals, about 165 patients, and those were the doses, and they showed an improvement, almost doubling of the time it would take to progress from the original cancer when they had the addition of the palbociclib, and improvement in survival was also modestly seen. And this was the schema where you had the letrozole, which would be normally what we would consider by itself for an estrogen receptor positive situation with recurrence, versus the combination. So that was kind of just a one-to-one randomization. It's known as one of the Palombo studies, and you can see the separation in curves that already talked to you about the improvement in disease-free survival. So that led to the FDA allowing us to have that drug added. Now, we do have to watch some things that are novel that we don't usually see with letrozole. Usually letrozole is more the estrogen deficiency effects, but palbociclib does affect the blood counts. Not that that's a big issue usually for most of us. And so, you know, the common effects that you would see with letrozole, like osteoporosis risk. But there is a rare risk with palbociclib, back to the question about why not use it early, a pulmonary embolism. And I probably have the only person in private practice that has it, but one of my patients early on, indeed, I gave palbociclib to, and she actually had a pulmonary embolism with her within about a month of her use of that. So that's probably the only case that I know of that anybody's used, because hundreds, if not thousands, of women have used it in this community. But it's just to let you know that there always are some issues about safety. And some people, of course, can die from pulmonary embolism. So obviously that's not something we want to make sure we're doing something that's safe. Recently, in January, I think it was, or December of this past year, we got approval, though. Remember how I talked to you about Fulvestrant earlier, how it degrades that receptor? Now we have evidence based upon a phase 3 study in women who were postmenopausal, and if they were premenopausal, we had things that were done to put them into menopause using Fulvestrant with or without palbociclib. And that study came out, we actually had seen things from ASCO last year that showed significant promise with that. The individuals who get the Fulvestrant, which was the injection, at the appropriate 500 milligram dosing, like I told you, with the drug or with placebo, and there was a significant disease improvement when, in fact, an improvement in survival was also realized with that by adding palbociclib. Okay, are you guys done, or should I stop? Or you guys want to hear a little bit more, or are we saturated, or you want to hear a few more things?
More things.
Yeah. Now, you're a boy, so you have to be careful. Okay, because there's not many boys in the audience.
I understand that, but I'm also connected.
Yes? Okay. Is that how that's going to work? Okay.
Well, I'm going to see.
Okay.
As I listen, the recurrence, is it just because it's dormant and it's there, or else after a while it begins to generate again?
No, most people, and that's the problem with what I'm presenting. I'm building a case as if it always will happen. Most individuals with hormone receptor positive breast cancer are cured. Most are cured. What we're trying to sort of show you is why research goes on, because something that we have always thought was so favorable that we find in some individuals that it doesn't work. And this is trying to give you an understanding of why would that be if we've done everything the same way. And it's been a trouble for us, not only in this type of breast cancer, but in triple negative breast cancer and HER2 positive breast cancer, and individuals who have other cancers. Because these things, when we have models for breast cancer, we can apply them to other diseases. I mean, I have treatments right now that I use for gastric that I use for breast, because the same mechanisms occur. So this is just really to sort of let people understand, we always don't worry about the hormone receptor positive patients. And you shouldn't, because the majority are cured. But in instances where they do develop changes, or they have it at the beginning, and they all look the same when they walk through the door in terms of the disease itself, why that happens. This is just a glimpse of why this happens, and what we're now, because we understand the different mechanisms that occur internally, how we're trying to get smarter to be able to use methods without too much harm to be more successful, to get those individuals a better chance for survival. But the majority of women with hormone receptor positive, it still is the one, God forbid if anyone chooses cancer and breast cancer, but it's still the one that you sort of kind of want to have, because there are other types that are much more aggressive. Though we have been more successful with, clearly with HER2 disease, but triple negative, which I'll be doing a talk later in the year about, it still remains a really big puzzle. But not this is not the majority. This is very much for that rare one. So that was actually a good question. Okay, now I'm glad that clears it up because I don't want. I know he's connected. I'm feeling the pressure up here, man. So I got it. Okay, so again, back to exemestane, an old drug relatively for our armamentarium for fighting breast cancer. It's one of the aromatase inhibitors, that adrenal gland and androgens and blocking with that enzyme. How about if we add something else to it? So you see the concept? If we got something that works, can we add something that may be more beneficial to maybe with more combined efforts stop the signal and get cancer control? So everolimus Afinitor is known as an mTOR, which stands for mammalian target of rapamycin inhibitor, mTOR inhibitor. And the value of this was actually looked in some Bolero studies, Bolero 2, which that time the acronym comes from breast cancer trials of oral everolimus. And patients in the study had actually had what we call a non-steroidal versus a steroidal aromatase inhibitor. I'm not sure that really matters too much for you all for tonight in the point of this, but they had already been on a drug called anastrozole, and then they were assigned to take exemestane, which when people have recurrent breast cancer and is hormone dependent, one of our strategies has been, that's been successful, is you use one estrogen blocker, and then if there is progression, you can go to another same class and actually achieve durable remissions and control. So that's another message that you all may not have known, that there are some individuals who've gone. I had one lady who'd been on estrogen blocker therapy for 10 years with metastatic cancer, and it never required anything more. So it is not inappropriate that if one has had one aromatase inhibitor to just go on to another one. So that was appropriate, and then they looked at that alone versus adding in this everolimus. And there was an improvement in the progression-free survival, improved overall response. There's really not been a real good clarification if it improves overall survival, but this was the design of the program. It was 700 plus women, a good study, and they were looking at side effects and benefits in terms of risk. Now, everolimus is also known as RAD-001. It actually was used early on in experience as an immune suppressant in organ transplant patients. But it actually affects that mTOR. And if you remember the earlier slide where that was really close to the nucleus, this drug blocks that. So if I can influence something that's close, again, if I want to stop that these guys were being rude and talking and I want to stop, and if I shake she's going to hit me later, you know, if I do that, then I can stop it because I'm more close. Whereas I'm over there and I'm trying to get people to settle down. Let's imagine it was some kids and they're really making, but you're not close to them. And telling someone, can you get to them and do it? If I'm closer to the nucleus, I can have more power to stop that message. Because the message is coming up from here, it's trying to go to the nucleus, and I'm stopping it close. So that's the idea in terms of adding something that is downstream in addition to the blockade of estrogen. So these are the strategies that makes sense in terms of what we're doing with this drug. And this is commercially available. We actually are doing a lot of clinical trials with it, and it's actually FDA approved. It does have a few side effects, though. Mouth sores, and actually we've done a wonderful study that's just been amazing that we want to share with the public, but you use just this mixture of mouthwash and we don't see much of any of the mouth sores that we used to see when you just use everolimus alone. It's just amazing things in terms of the efforts that people were saying to just get this drug out there and longer, but it does sometimes have an inflammation of the lungs, so you have to really, if someone's on it, talk to them about pulmonary symptoms, and if they have changes there, it can have some mild changes in the liver enzymes. The point is that even though there's good things, there's sometimes side effects and dangers with this. And then there was a study that was looking at RAD, the RAD-001, where tamoxifen was one acronym, and it also showed benefit in premenopausal women. So another concept, and I'm bouncing now back to some different concepts. In December of 2015, I don't know if you all know, I think many of you do because you seem to be very up in terms of breast cancer in this town, but you all know that San Antonio, Texas hosts every year an amazing international meeting of scientists from all over the world, and they come in December and share. Have you heard San Antonio Breast Symposium? And actually one of the groups in town that we work with, the Alamo Breast Cancer Foundation, actually facilitates survivors to go to that every December, and they have a mentor session, and we'll certainly, when that comes around, we'll make sure you all know about it. It's an amazing, amazing place. Well, and I go to those meetings because I want to know what's going on, because you guys are going to ask me, I heard something on TV or I read in the newspaper that they were doing this, right? Well, this is one of the things that came out that I was cognizant of for years, because we've been looking at medicines that affect osteoporosis. So osteoporosis, bone density, bone density problems. We lose bone density when I take your estrogen away, or I give you an estrogen blocker. Darn me, Dr. Wilks, right? So I've been really interested in bone health anyway, because a lot of my patients get osteoporosis when they take these strategies. So denosumab, or Prolia, has anyone heard about Prolia? Yeah, that is a drug that is a fully humanized monoclonal antibody that attacks a special area of the bone system called rank ligand, and it's a rank ligand inhibitor. The mechanism of action is that there's precursors to the cells that actually cause erosion of bone called osteoclasts, pre-osteoclasts, that express this rank. And rank is activated by this rank ligand and promotes these osteoclasts. The osteoclasts and the bone destroy and erode it away. Osteoblasts build up bone. And this process allows for increased bone destruction. So as we age, this is a real key influence on cancer, on bone density. This process is a fluid, bone is a living structure, so there's correction. You don't want to have too much bone formation, so you have to have something that kind of keeps it in check, so that's why osteoclasts are necessary, but then you can have an excess of activity, particularly in absence of estrogen and as we age. So denosumab inhibits this area that influences the osteoclast and bone destruction by binding and inhibiting this ligand, and this prevents the degradation and has a reversal. So if you have osteoporosis and you take it, you can actually have improvement of bone density. And so it's actually been used not only for osteoporosis prevention twice a year, but it's actually in individuals who have recurrent breast cancer that travels to the bone. We actually see this drug being useful there. So the question was raised, and this is because of some observations. When breast cancer that is hormone receptor positive, where do you think is well, this is probably an easy answer now. What's the most likely vulnerable organ that breast cancer that's hormone receptor positive goes to? Who said that? You were right, you were listening. Bone. And what is it about bone? And I'm a hematologist too, and I look at marrow, and there's a lot of things that go on inside of the marrow where the bone houses it, that it sends off different messages. So we really wonder if there's some things that are going on inside the bone marrow that influences cancer growth. And I have a little cartoon to show that a little bit, but that's right. Bone is one of the most common places it goes. So if we're doing something that may help with bone, and there may be messengers that we can turn off that may promote cancer going and settling in bone, could it prevent breast cancer recurrence? So there were some preclinical, Petri dish studies that had shown that denosumab actually inhibited bone destruction and tumor burden that had gone to bone. In early breast cancer, as I made the point, microscopic deposits of cancer may travel to the bone. Again, remember the blood circulation goes into the bone marrow, so there's an easy connection. So we wonder if the microscopic deposits go there. And so the aim of some of these studies were to kind of look at whether or not there would be some value in terms of using a medicine that affects bone density in this process. So you see this osteoclast? I don't see if you see the labels all the way in the back, but this is an osteoclast, little Pac-Man looking kind of thing. There's a concern that this process can secrete things that can promote tumor growth. We know that. So, if you do something here to the osteoclast, maybe we could suppress tumor production is the theory in terms of what we wonder in terms of benefit. And sure enough, when they started to do some studies and they used this denosumab depicted by these little yellow extenders and bind to the different areas, that there was really some effects that they saw that directly on tumor growth, that there was a reduction in tumor growth. Again, you can see this in Petri dishes in terms of just exposing that drug to them that could stop cancer growth. So we knew that there was conceptually something, but again, like everything that you see in the test tube or animal studies, is it really going to manifest any value in people, as a value? So one of the things is we wanted to make sure that it might help people who are going through, if I'm putting them on that ovarian function suppression drug and creating menopause, can I help them not have as much bone destruction? So we think it should be beneficial, but we want to see if there's some value to that. So there was this study, the impact of adjuvant. After the person has had surgery, they have breast cancer, hormone receptor positive, can we use this drug and it's an impact disease-free survival? Will a drug that fights osteoporosis help disease? And so it was one-to-one randomization. Some people got placebo, some people got denosumab. after they had had their initial treatment for breast cancer. That was the study design. And this was presented at the San Antonio meeting. And then again, the curves are subtle, but these are very significant in terms of changes, that by adding the denosumab, there was an improvement in just adding a drug that prevents bone loss and the person's chance for recurrence of breast cancer. And if they had larger tumors where the risk was greater, it was more substantial of a benefit. So when we have women come in who develop osteoporosis with treatments that we use for breast cancer, this is now a situation, if we have it, since Prolia is on the market, we actually consider using this drug because it may not only prevent you from getting weak bones and fractures, but it actually may improve your survival rate. December 2015, right here in San Antonio, presented, guys.
Do you have to wait until they show signs of osteoporosis?
Because we don't know whether the mechanism in terms of prevention is good. So no, we don't. And then it comes down to insurance. So, you know, but the idea is that just like the early question, why wouldn't you use it early then? But again, we don't know if that has the same influence, because again, you have to have an overexpression or the overactivity of the osteoclasts, and if they're not really over and we're targeting that, then that might not influence things the same way. So again, I don't know that it would be beneficial, but because we don't know that, that's why we're not routinely using it. But if there is a situation where that develops and you're getting your bone density tests frequently, you can catch it early. And remember, it reverses it reverses osteoporosis. Now, this is just to remind you, and this is just, you can't read it from the back, all the areas of research to fight this disease. The mTOR inhibitors, the SRC inhibitors, cell cycle inhibitors, farnesyltransferase. I don't want you necessarily to remember all these things, but this is research right now. Trying to now take things where we've got estrogen blockade, but saying let's do something more, because if we can get smarter in terms of what's driving this cancer growth, then maybe we can influence it. So I'm going to just go through, I'll talk to you about the PI3 kinase pathway. Remember that pathway that was in there that drives cancer growth? That's a really hot ticket. We have some studies, a lot of folks in town are doing this too, where we have inhibitors of that pathway along with like letrozole to use it even in people who are early diagnosed with breast cancer. Significant research ongoing. That CD4, that cyclin-dependent kinase area, we have palbociclib that I talked to you about earlier. We just opened a trial that's looking at 2 other drugs that work in that same area, because again, maybe that'll be a little bit safer and maybe a little bit more effective. So the research is not done. We're looking at that. And then these mutations. One of the things that I'm not going to spend too much time, I know people are kind of antsy to get going, but the mutations that develop after you're exposed to treatment, in other words, changing the process to a more difficult process to eradicate, these mutations are really intriguing to us in terms of trying to target them for breast cancer management, and that these mutations sort of in this area, again, that's why I showed you the estrogen receptor alpha and beta earlier. This is in this area, the estrogen receptor alpha, and these mutations on this certain part of the domains are activated. These mutations that make the cancer still grow. We know that that develops more after you have exposure to estrogen blockade. And so what this slide shows is that after you have someone who has a primary breast cancer and then they're treated with an aromatase inhibitor or tamoxifen, you start to notice a development, particularly after AI, of about 20 to 50% of the patients, if they go on to have progression of disease, will have these mutations there. So the treatment is now making the disease, because it's trying to figure out a way how to survive. So it mutates. And so this is just an example to you of what science has found in terms of what we now realize because of that, how we can target. Because once you know what the change is, you can design a drug to fight it. And that's exactly what's going on. We have a trial that's looking at this aurora kinase. There's a little picture about that. Another, I talked to you about the Fulvestrant. It's an injection. Well, we're actually doing a study in our practice, and there's a couple other places in the country that looks at a tablet that doesn't require the injections. And this drug is really intriguing to me, the one that we're studying, because it may reduce cells passing to the brain and may reduce brain recurrences from breast cancer. And of course, it's oral. So this is the slide to just remind you that what I just, some of you all survived. You stayed through the whole thing. I went over the history. Always can learn a lot about his history. Sometimes it's humbling. You know, they were doing pretty well. Sometimes we're just removing the ovaries and not even understanding why all these things were working. Explain a little bit about how the tumor grows and the estrogen receptor signaling. Previous therapies that we now still use, tamoxifen, aromatase inhibitors, they still work. But there's this resistance that sometimes occurs in some patients. Some of the new strategies to improve upon, particularly for higher risk young women, maybe node positive, maybe we want to add the extra creation of menopause and maybe add an AI, maybe extending again tamoxifen longer, dosing. Sometimes just increasing the dose might be safe and maybe better. The new agents, and there's a plethora of new agents, even using something for osteoporosis that may be beneficial, and then of course a lot of novel agents. And so with this slide, I would say thank you so much for the honor to speak to you all today and coming out to support the Alamo City Cancer Council. Now, I know everyone's been a little fatigued, but if there's any questions, I'll take them. If not, and if folks want to come down individually, we can do that. But are there any questions? I'll just say the general group.
She didn't get it treated. She did.
How do we treat DCIS?
What are you trying to do now?
The same drugs that we use for invasive.
Same time frame?
Same time frame. So DCIS is a precursor to invasive breast cancer, and we have to test that just like we do invasive breast cancer for whether the doorway, the estrogen receptor and progesterone receptor are present. If they are and they're premenopausal, we use tamoxifen or recommend a consideration of that. We wouldn't use ovarian function suppression there because of the challenges there. But if they're postmenopausal, we would use an aromatase inhibitor. Other questions? Well, props to you all for staying and hanging in there with me. I hope you learned something tonight. That's what we're about in the Alamo City Cancer Council, is empower you with more information, get you excited about some of the things that are going on in San Antonio.